Before beginning the procedure, obtain written informed consent. Risks of pulmonary injury, bleeding, and infection should be discussed. Position the patient sitting upright on the bed with arms resting on a bedside table. An assistant should accompany the patient during the procedure to prevent falls or injuries should the patient feel lightheaded or have a syncopal episode. Monitor the patient's heart rate, blood pressure, and oxygen saturation during the thoracentesis, and apply supplemental oxygen if clinically indicated. Next, determine the height of the pleural effusion. In this example, bedside ultrasound is used to locate the effusion. Note that the pleural fluid, which is anechoic and appears black, is easily visualized, as is the diaphragm and the collapsed ipsilateral lung. If ultrasound is not available, the height of the effusion should be determined via auscultation and percussion. Mark the needle entry site with a skin marking pen. Needle entry should occur at least one interspace below the top of the effusion in the posterior hemithorax line. The needle should not enter below the 9th rib in order to avoid iatrogenic injury to the diaphragm and interabdominal structures. As a rough guideline, the inferior pole of the scapula rests at the level of the 7th rib. Lay out all the equipment on a bedside table and don sterile gloves. Cleanse the skin around the needle entry site with chlorhexidine or povidone iodine, using gradually increasing concentric circles beginning at the needle entry site. Once the area has been prepared, apply a sterile fenestrated drape. Using a 25-gauge needle, place a wheel of anesthetic over the superior surface of the selected rib. Advance the needle through the wheel until it comes into contact with the rib, and then gently walk the needle over the superior surface of the rib. This technique avoids injury to the neurovascular bundle that runs along the inferior surface. Continue to advance the needle, alternatively injecting anesthetic and pulling back on the plunger. Pleural fluid will enter the syringe once the thoracic cavity has been entered. Inject additional anesthetic to anesthetize the highly sensitive parietal pleura. Note the depth of penetration and then withdraw the needle from the chest. In general, between 5 and 10 milliliters of local anesthetic are used. Prepare the thoracentesis catheter by attaching a 10 milliliter syringe to the back of the catheter. Rotate the catheter around the needle to break the factory seal that may be present. If a thoracentesis catheter is not available, the procedure may be performed with an intravenous catheter in an analogous fashion as described below. Before proceeding with thoracentesis, create a small nick in the skin with a 16 to 18 gauge needle or an 11 blade scalpel to facilitate passage of the catheter through the epidermis. Hold the back end of the catheter in your dominant hand. Rest the dorsal surface of your non-dominant hand on the patient's back and use the thumb and index finger of this hand to steady the shaft of the needle. Insert the tip of the needle into the skin nick and advance the catheter until it comes into contact with the rib. Then slowly walk the catheter over the rib. Pull back on the plunger as you advance. Entry into the pleural cavity will be heralded by the aspiration of fluid into the syringe. Immediately stop advancement once fluid is obtained. Gently advance the catheter over the needle and into the pleural cavity. Be careful to not advance the needle at this point in order to avoid iatrogenic pulmonary injury. Hold the catheter in place and then carefully remove the needle. It is extremely important to cover the catheter hub with your finger once the needle has been removed to prevent entry of air into the pleural cavity, which could lead to pneumothorax. Remember, never leave the catheter hub open to the atmosphere during thoracentesis. You may choose to attach a 3-way stopcock to the catheter hub, which helps prevent air entry into the pleural cavity. If using a stopcock, it should be open to the patient only when actively draining pleural fluid. Note that a collection syringe or tubing may be attached directly to the stopcock, which facilitates sample collection. Attach a large syringe to the catheter hub or stopcock and withdraw 30 to 60 milliliters of fluid for diagnostic evaluation. Once fluid collection is complete, remove the syringe and re-occlude the catheter hub with your thumb or by closing the stopcock to the patient. If additional fluid needs to be removed for therapeutic purposes, attach high-pressure drainage tubing to the catheter hub or stopcock, again taking care not to leave the hub exposed to the atmosphere. Insert the other end of the tubing into the evacuated container and allow the pleural cavity to drain. In general, no more than 1,500 milliliters of fluid should be removed to prevent the development of post-expansion pulmonary edema. Once the drainage of pleural fluid is complete, remove the catheter from the patient at end exhalation. Remove the sterile drape, wash away any remaining skin cleansing agent, and apply a sterile occlusive dressing over the needle entry site. Post-procedure radiography is not mandatory after simple, uncomplicated thoracentesis, since iatrogenic pneumothorax in these situations is rare. However, a chest X-ray should be obtained if air was aspirated during the procedure, if chest pain, dyspnea, or hypoxemia develops, if multiple needle passes were required, or if the patient is critically ill or receiving mechanical ventilation. Pleural fluid should be promptly transferred to appropriate collection tubes and submitted to the laboratory for analysis. A tube without additives is submitted for LDH and protein analysis, and an EDTA tube is submitted for cell count and differential. Aerobic and anaerobic culture bottles should be inoculated at the bedside if infectious etiologies are of concern. Additional tests may be required depending on the clinical scenario, and these are discussed in further detail in the written portion of this chapter. The first step in pleural fluid analysis is determining whether the effusion is a transudate or exudate by applying Light's criteria. Transudates are caused by increased hydrostatic pressure in the vascular space, such as in cases of congestive heart failure and cirrhosis. Exudates are caused by either increased capillary permeability or lymphatic obstruction, such as in the case of cancer or infection.